Good evening, students, and welcome to these pocket clinics. All you doctors, wherever you are, I hope you're in good health. And let's quickly see how we manage a lady who's come to us with a white discharge. So, when we are talking about women having white discharge, first of all, we can go with all the classifications and we can do all the assessments. We can do a lot of, description of the disease. But first thing first, I will always want all of you, wherever you are having a gynae practice, or you're not a gynecologist but you are the first doctor who is going to take care of patients coming to, you're doing the the first examination of a lady who's come with the preliminary complaints. Whenever you see a woman with white discharge, please don't think it is always candidiasis. Don't think it is always curdy white and it is always treated by giving a oral fluconazole or a vaginal clotrimazole. Please, that is one thing which is setting into all practice, and I've seen this with numerous doctors, and I feel that we are being a little careless when we just listen to the symptoms and assume that she's having just white discharge and it has to be curdy. You will tell her 3 times, yes, it is curd like, yes, it is like paneer type. You'll ask her and then she'll say, हाँ ऐसा ही है कुछ doctor साहब, and you'll just give her that. Please always examine, because you could be missing a malignancy. You could be missing something like a serious sexually transmitted infection, which is not just candidiasis. Always examine. Please do not just treat the symptom, examine a lady. Right. So when we do the classification of vaginal discharge, how we describe vaginal discharge, remember, it can always be physiological, but it can be many other things. It could be infections like Neisseria, and it could be vulvovaginal candidiasis, and it could be bacterial vaginosis. Remember, bacterial vaginosis is the most common vaginitis. There's a lot of discussion that this is basically a commensal which is causing problem. So technically it is not a vaginitis. Look, all that talk, we can keep it in the background. Bacterial vaginosis is known to cause, in pregnancy, it is known to cause PID, it is known to cause chorioamnionitis, it is known to cause preterm labor, abortions, intrauterine death of fetus. A woman with bacterial vaginosis, if you don't treat, whatever PID you treat, and if you don't treat bacterial vaginosis, it is the known cause of recurrence of PID. I think it causes enough. So please consider it as a vaginitis and don't get into the technicalities when you, especially some of you are still writing exams. I don't want you to get into too many technicalities that you miss out on simple answers. And please remember, this is indeed the most common vaginitis. I'll be talking about that just a little while later. Yes, discharges can be because of trichomoniasis, and that is a typical greenish frothy discharge which you see in trichomoniasis, and it can be also because of systemic toxic shock syndrome, classically because of staph, right? Then it can be because of inflammatory causes like Crohn's disease or the collagen vascular diseases, can be because of chemical irritants and too much of douching. Yay, look at this point, guys. Now, a lot of you are caring for women, and a lot of you want the women hygiene to be taken care of by these exciting new products known as the vaginal douches. I'm not supposed to take names of all the products which are available in the market. Please, we are in an Indian setup, and women in developing countries or underdeveloped countries are not very well educated to understand that they're having an infection or a physiological discharge or a shift in pH. I mean, a lot of educated women also don't know that. So please, do not just listen to the symptoms and tell her to take that wash and this wash and douse the vagina, because it will change your pH, because a shift in pH can cause infections. Yes, truly it can cause. So you can take these douches which can take care of the infections. Please, shift in pH can cause infections, but a patient doesn't know that she's about to have infection or she's having a florid infection. Now, what happens when the women start taking these douching? These douchings are known to cause, I mean, they are going to give a immediate relief of 10-15 minutes, but they're going to make a wet, sodden vulva and vagina. And if there is an infection, which most probably it is, if there's infection, it is going to get flared up. All of you know that if there's a moist perineum and a moist vulva and a moist vagina, it's going to increase infections. It's going to, you can imagine if somebody has even a man or a woman, anybody having a moist perineum, it's going to cause more infections. So I have seen patients with florid vaginitis and untreatable. I mean, they've gone to hundreds of clinics. They've been suffering for 2-3 years and they're saying, sir, 10 दिन का आराम आता है, फिर से शुरू हो जाता है, and I'm sick of taking these these tablets from so many doctors. And then I'll ask her first question, what type of douching are you using? Which is the best douch you use? Sir, I'm using this one. It is the most expensive one in the market. And then I'll have a smile on my face and I'll tell, please throw that douch out of the window. Or you can use it to, if you bought it and invested, you can use it to wipe your floor and clean it. Maybe your car, but not the vagina. Please, this douching is causing so much of problem that I have become, a sort of a favorite doctors with a few patients because I've taken the douching away from their, daily routine. So you do not have to clean the vagina from inside. Tell these patients that a vagina can take care of itself. And if there's an infection in the vagina, the doctor is there to take care of it. Yes, this is something which is missed. And I'm not anti, vaginal hygiene, but I'm not pro too much of vaginal hygiene. So whenever a lady is going to the loo, we always advise women to clean backwards. Don't clean frontwards. Men can do whatever they want when they want to clean themselves when they're going to, defecate in the morning. But women, we always say clean backwards, and you can use gentle tap water to, clean yourself after going to the loo, and you don't have to vigorously wash the vulval area, the vaginal area. Internal cleaning and all of that is detrimental more than anything. All right. So something straight out of my practice, I'm telling you. Right, let's see. Inflammatory conditions can be because these chemical irritants and douching, and dermatological lesions like lichen planus and atrophic vaginitis. Yes, it can be neoplastic lesions also. Precisely why I was telling you that it is very important that a woman always gets examined when she's got a discharge, and that can be because of this persistent atypical bloody discharge because of endometrial malignancy. They can be postcoital bleeding because of CS cervix. The most common presentation of CS cervix in fact is postcoital bleeding immediately after sex, and they could be also vulval and vaginal lesions which could be the cause of this bleeding. Right, so those are the etiological framework which we have to keep in mind. So if there is a patient when you examine and the patient has a clear white discharge, so that's most likely physiological. So that's why I said that if a woman has a discharge, you must examine her, and when you examine, you could see a clear white discharge, and she's worried, sir, whenever I clean up in the night when I'm sleeping, the whole day I'm wearing an undergarment, and when I'm cleaning up in the night before sleeping, I see there is a minimal discharge on my undergarment. That's all right. A lot of women have it, and it is going to increase during the ovulation time, and it's just a little bit of a sticky fluid which comes out of the vagina. That's all right. It's not going to be having lumps and clumps, and it's not going to have thick coagulants in the discharge. If that is not there, and it's just thin sticky discharge which is there in a lot of women, that's perfectly all right. Cervical mucus is mucus, sticky, right? Minimal discharge is fine. So normal physiological discharge which can be seen, or pregnancy related discharge, or ovulation related discharge, it can all be there. Then of course yeast infection will also be white, but then always examine to be very sure. Yellow green, it can be because of trichomoniasis. Grayish can be strongly associated with bacterial vaginosis, that grayish creamy discharge classical of bacterial vaginosis. And reddish pink discharge can be, of course, she could be in her periods which are irregular. And she said she had a periods which is she had on 1st of June for 4 days, and now on 18th of June, 19th of June, she's again having some spotting. So it could be some irregular periods also, or it could be some cervical bleeding, it could be polyps, and it could be a potential neoplasm also. Again, it goes back to the same thing which I'm saying, always examine a lady when she's got any discharge. And then remember the normal physiological discharge which I was trying to tell you earlier in this slide, that it is around 1 to 4 ml in 24 hours, and it is mostly odorless. If there's an infection, then it will be generally having some kind of an odor, so you should always be on the lookout for that. Right, so how do you distinguish the basic general vaginitis? I'm not going to the topic of sexually transmitted diseases right now. I'm just trying to tell you that if there's an infection and if there is not an infection, how do you make that out? So vaginitis, if I tell you just a very simple comparison, you must know that bacterial vaginitis, bacterial vaginosis is the most common form of vaginitis. It's got a thin off-white or grayish, like we say, it's thin off-white or gray discharge, creamy discharge. The word which we always say is creamy discharge in a case of bacterial vaginosis. And generally, there will be no inflammation in that because, yes, it is known to cause more serious problems inside the body than obvious inflammation in the vagina. And yes, if you do a lab testing on the microscope, you're going to see something called the clue cells. These clue cells are the epithelial cells, the vaginal cells with a lot of bacteria on it. Okay, so epithelial cells with embedded bacteria is what is known as the clue cells. Clue cells is classic. I mean, some of you are students who are watching this, and you must know that clue cells is a general question in almost all the exams. You must know that. And pH is more than 4.5, and there's a positive whiff test. That is, if you add potassium hydroxide to the secretions, you'll get an ammoniacal smell, ammoniacal odor, and the treatment is metronidazole. Trichomoniasis is again in a pH which is more than 4.5. So more than 4.5 here and more than 4.5 here. So that is what is pertaining towards alkalinity. Look, if it is 6, it is still in the zone of being acidic, but it is lesser acidic than normal. More than 7 is alkaline. All of us know that more than 7 is alkaline, but normal is 4.5. So from 4.5, suppose the pH shifts to 6.5. So it is still acidic, but it is pertaining towards alkalinity. So that shift in pH from acidic to lesser acidic is what is known to cause the trichomoniasis and bacterial vaginosis. So just a shift in pH and also an absolute alkalinity, which is more than 7, are favoring these two infections, the bacterial vaginosis and trichomoniasis. And of course, on the microscope, you will see these motile trichomonads. Now, these trichomonads, the trophozoite forms of these Trichomonas vaginalis. Now, these are the reasons. These are the bugs. They are around 30 to 40 microns in size, and these are the bugs which are known to cause that severe itching because they're always moving up and down in the vaginal area, and that causes severe pruritus. And that severe pruritus and that severe inflammation which happens gives these red macules. So macules in the vagina. Vagina is known as, in Latin we call it colpos, and macule. So we call it colpitis macularis. In regular terms, we call it strawberry vagina because you'll see red macules on the cervix and in the vagina. So strawberry vagina or colpitis macularis. And the treatment is, of course, metronidazole. You must always treat the partner also because this is sexually transmitted. You'll be surprised to know that trichomoniasis, the chance of transmission to the partner with one sexual intercourse, yes, is more than 70%. So always treat the partner in trichomoniasis. Even HIV is not, HIV, we keep saying that one act of intercourse, the chance of the partner contracting that is less than 1%, but in trichomoniasis is more than 70%. Okay, and candidiasis, of course, is the classical curdy white discharge. It's seen in the acidic pH. Okay, the normal pH of the body. It's a thick cottage cheese type of discharge, and there is a lot of inflammation. And on the microscope, you will see the pseudohyphae, and the treatment is fluconazole. So this is just a simple outlook. Let's look precisely at a few things regarding these vaginitis. So when we see bacterial vaginosis, it is 50% of all the vaginitis cases. Like I told you earlier, the most common vaginitis is indeed bacterial vaginosis. Now, bacterial vaginosis is most common of vaginal symptoms in reproductive age, and it is having this thin homogeneous discharge. Okay, vaginal pH is more than 4.5, and positive whiff test, which I told you that if on the secretions, if you add potassium hydroxide, it gives a ammoniacal odor, and there will be clue cells visible that I told you, the vaginal epithelial cells with embedded bacteria, along with a fishy odor. So these 5 criteria are known as the Amsel's criteria. The microbiologist will also teach you something called the Nugent's criteria for the diagnosis of bacterial vaginosis, but we must know the Amsel's criteria clinically. So any 3 or more, 3 at least should be there to diagnose bacterial vaginosis, and it's a very common bug. And you must treat this. Of course, if a woman has a much severe inflammation, pelvic inflammatory disease, let's say the whole pelvis, the uterus, the broad ligament, the tubes and the ovaries, everything is inflamed, that is known as pelvic inflammatory disease. You will treat it with big drugs, but don't forget to use metronidazole, which is going to kill the bacterial vaginosis. Why? Because this is the bug which is going to cause relapse of PIDs. So that's the important information about bacterial vaginosis, most common vaginitis, and the bug which is responsible for the relapse of PID. Right. So treatment protocols, let's see, management of white discharge, let's see candidiasis first. So candidiasis, you can give, these are some trade names I'm giving you here, Candid V6 cream, or we can have these tablets, vaginal Cansoft tablets, you have Candid tablets, you have these Klingen 4 tablets. There are many names which are there. So this Candid V6 cream, Cansoft CL, that is CL means for clindamycin. Clindamycin is going to take care of the bacterial vaginosis. It's a anti-anaerobic kind of a drug, right? So clindamycin with clotrimazole or Candid V6, you can give it directly into the vagina at bedtime, and you can also give oral therapy for candidiasis, and that the only oral drug which is approved for vaginal candidiasis is fluconazole. Look, there are many antifungals like itraconazole and voriconazole and terbinafine. You don't have to give all of them immediately when a woman has, a lot of doctors I've seen, they will not even examine and write itraconazole straight away. I mean, those drugs are reserved for something like systemic candidiasis, systemic fungal infections. So we are not going to give that, use the Bofors gun for a small bug like this, isn't it? You can use a fly swatter for a small bug. So something like that. So fluconazole is that simple oral antifungal drug. Just one tablet is enough. Of course, we'll talk some other place about recurrent vulvovaginitis with candidiasis. So what can be the treatment of that? And the complicated candidiasis, like we call it. Simple candidiasis, which you see first time patients presenting, and if you want to give her oral drug, that is fluconazole. It is highly effective, right? Then syndromic approach. Okay. Now, I told you bacterial vaginosis is not sexually transmitted. Trichomoniasis, treat the partner. But in candidiasis, it's not sexually transmitted, but it is better to treat the partner. Look, if you ask me in the term of, let's say you're writing an MCQ exam and you say, should you treat the partner in candidiasis? If a woman has candidiasis, should you treat the partner? I'll say no, because it's not sexually transmitted. But you know that fungal infections are transmitted because of proximity, because of using articles. I mean, a couple is using the same room, they're sleeping in the same bed, and they're using the same towel, they're using the same bed sheets. So fungal infections do move around with proximity. So it's better to treat the partner. That's what we say. Clinical practice. Okay, you and me are talking about pocket clinics, basic rules of managing patients, right? So we will give a syndromic approach. We'll give a partner kit also. There are a lot of these kits available in the market. I'm not naming them right now. Fluconazole for the candidiasis, and then the azithromycin and ornidazole for the PID if it is settling in. I mean, the patient has got this white discharge and she's got some pain abdomen and she doesn't want to be examined, and or you are in a setup which is like a setup where you are in a primary health center and there are no facilities for examining, and the woman is not very interested to get examined at that time. Sometimes you just have the syndromic approach. There are so many kits available, and one of these is this favorite combination which is given for treating, and you can give it to the partner as well. Then management of white discharge when we're talking about trichomoniasis and bacterial vaginosis. So trichomoniasis, Trichomonas vaginalis protocol is primary treatment is to give metronidazole. If you see the Western books, they'll say 500 milligram. In our country, the tablet of metronidazole available is 400 milligrams. So we can give it twice a day or thrice a day for 7 days. And alternative regime is tinidazole 2 grams orally in a single dose. And what's the management of bacterial? Remember the clinical rule that both the partners should be treated concurrently, because this trichomoniasis has a 70% chance of transmission even with one sexual act. Then bacterial vaginosis, again the drug is metronidazole, and alternative drug you can give clindamycin, like I told you earlier. Bacterial vaginosis, you need to take care, because bacterial vaginosis is a reason for relapse of PID. Right. So a lot of students were here and they were asking me some doubts. So how to know? Real student 95. What are you asking me? How to know? Yeah, that's what I've been telling you. I mean, if you join late, all you can do is just pause, stop this, rewind and play again. All right. So that's what we told you, how to know what infection is happening, right? So remember that when a patient is being given metronidazole, always avoid alcohol. Look, a lot of us are trying to be polite and we don't ask this question. But I have made it a habit that whenever I'm writing metronidazole, even to a lady, please ask her that if you're consuming alcohol, please don't take metronidazole, or if you're taking metronidazole, don't take alcohol, because that disulfiram reaction can cause a lot of vomiting and a lot of dysphoria and a lot of discomfort, cramps in the abdomen, and that can happen. So women will mostly nowadays tell us that if they are taking alcohol, and always tell them to abstain from alcohol. Okay, of course, if you give it to the partner also, you must remind that the partner also should not be taking that. Right. So, what is the flow chart when a patient has white discharge? Once again, because my friend was asking, so here is the summary. Remember, always take the history and assess the risk. Assessment of the discharge features, what is the color, consistency, and if there is any odor, and if there is associated pruritus. Because if there is trichomoniasis, candidiasis, there will be pruritus, but in a case of bacterial vaginosis, there will be no pruritus, no itching. And then if there is any pain, then office diagnostics you can do in the OPD itself. You can do an examination, always examination first, and check the pH. You have these simple pH papers which are available. Most of my residents, they have these pH papers in their pockets, and we use it for many things in gynecology and even obstetrics. In premature rupture of membranes, when we have a doubt, again we use the pH papers, right? So, and you can also do the KOH test, whiff test, can be done in the clinic itself. On the discharge, you have to add just potassium hydroxide. And wet mount prep. Now, 1 drop, you have a cotton swab available in the OPD. Just whatever discharge you see, you just dab that cotton swab and take that drop of vaginal secretion, put it on a slide, add 2 drops of saline, put a micro slide on that, put a cover slip on the slide, and then look it under the microscope, and you will get to know if there are these motile trachomonads. We used to do this in my college. I remember in JIPMA, we used to have this small small lab. The OPD lab used to be, of course, there used to be big lab, central lab, but there's an OPD lab in which all we had to do was just dab the secretions, go take it to the side lab, and our good friend who will be the lab technician will be there. He'll show us also that you just look under the microscope, you'll see these motile trachomonads, and you can see this fungal hyphae also. And then targeted therapy, prescribe pathogen specific therapy, treat partners in trichomonas vaginalis, counsel on compliance and avoidance of alcohol. So, I am just giving a summary of whatever we were discussing earlier. So, can we ask doubts? Yes, I watched record videos on PW video. Yes, you can ask me doubts. Yes, I am here, very much here, because we have finished this chapter here. But if you have any doubts, I am very much here to take it out. So, why not use this for regular education also. Go ahead, shoot it out. The Rishang Dusane, right? Okay, so if you're not asking me anymore any doubts, then maybe I can call it a evening for you guys, and it's Saturday. Might as well take a short break and watch a movie and get back to reading from tomorrow morning, right? And match day tomorrow, we have a match, cricket match coming up, we have a football match coming up, and good old friend Surya Kumar Yadav, I'm missing you wherever you are. I hope you get back to the team as early as possible. Right, guys, thank you so much for your patient listening. We'll get back for more on POC clinics. Thank you so much.